All right, welcome everyone to this explainer on G6PD deficiency. Today, we're setting the stage for a really high-yield dive into a potentially fatal ED presentation. Look, whether your patient rolls in with abrupt jaundice or just sudden severe anemia, understanding the acute hemolytic crisis is absolutely crucial for rapid, life-saving intervention. So here's our roadmap for today. We'll quickly cover the concept and pathophysiology, jump into triggers and favism, look at clinical and lab diagnoses, establish our emergency management algorithm, uncover a really dangerous methemoglobinemia trap, and finish up with our key messages. Let's get right into it.
Part 1. Concept and Pathophysiology. Let's look at the cell's main defender.
You know, G6PD is basically a vital housekeeping enzyme present in all our cells. It's an X-linked enzymopathy, which means we're mostly talking about male patients here, though females can for sure be affected depending on X chromosome inactivation. We're looking at roughly 400 million people affected worldwide, especially folks from the malaria belt. Now, mature erythrocytes, they are uniquely vulnerable here. Because they don't have nuclei, they literally cannot replace damaged proteins or repair themselves. They rely entirely on G6PD to defend against oxidative stress. No backup plan whatsoever.
Think of the mechanism like this. G6PD is the gatekeeper. It catalyzes the very first rate-limiting step of the pentose phosphate pathway. Its main gig is converting NADP+ into its reduced form NADPH. And why do we care? Well, because NADPH is the fuel that regenerates reduced glutathione. That reduced glutathione is the ultimate shield. It neutralizes reactive oxygen species and essentially stops the red blood cell's membrane and hemoglobin from just tearing themselves apart.
Let's put a normal state right up against a deficient state. In a healthy red blood cell, reactive oxygen species get neutralized instantly, no problem. But in a G6PD deficient cell, NADPH production just plummets. The cell's glutathione reserve completely collapses the second it faces oxidative stress. And without that shield, unneutralized reactive oxygen species just run rampant. They oxidize and denature hemoglobin, cross-link with membrane proteins, the cell membrane gets incredibly stiff, loses its deformability, and finally it ruptures. Boom. Severe hemolysis.
Moving on to Part 2, Triggers and Favism. We need to talk about the catalysts.
So the tricky thing is that these patients are usually walking around totally asymptomatic until a catalyst tips the scales into a full-blown hemolytic crisis. By far, the most common trigger you're going to see in the ED is an acute infection. But right on its heels are some very specific high-risk medications. We're talking about drugs like dapsone, rasburicase, the antimalarial primaquine, pegloticase, and the urinary analgesic phenoxypyridine.
What's crazy about these high-risk drugs is the complete lack of structural similarity between them. I mean, antimalarials are grouped right next to antibacterials and analgesics. Chemically, they don't look alike at all. But what they do share is this powerful ability to stimulate the pentose phosphate pathway, which rapidly drains whatever little NADPH a G6PD deficient patient has left. And then, of course, we have favism. Fun fact, even the ancient philosopher Pythagoras warned his followers to stay away from fava beans, likely because he saw this exact explosive reaction happening. Favism is a severe, sometimes entirely life-threatening acute hemolytic anemia triggered just by eating fava beans. The beans are packed with compounds called visine and convisine that generate massive oxidative stress. Now here's a crucial clinical distinction to lock in. While every single patient with favism has G6PD deficiency, not all G6PD deficient patients are going to react to fava beans. But when they do, the hemolysis is explosive.
Okay, Part 3. Clinical and lab diagnosis. What does this actually look like at the bedside?
You're looking for that classic triad, right? Abrupt jaundice, dark urine from the hemoglobinuria, and fatigue from the sudden anemia. When you pull your rapid ED labs, you're confirming both intravascular and extravascular hemolysis. You're going to see rapidly declining hemoglobin, a spike in LDH, a dramatic drop in haptoglobin as it binds up all that free hemoglobin, a surging reticulocyte count as the marrow desperately tries to keep up, and indirect hyperbilirubinemia.
When we check the blood smear, it shows us the early signs of a crisis. Just keep in mind, the oldest red blood cells circulating in the patient's body have the absolute lowest amount of remaining G6PD enzyme. So, naturally, they're the very first ones to hemolyze. As the oxidative attack drags on, that destruction just walks its way upstream to younger and younger cells.
Here's where it gets really interesting. The reticuloendothelial system. The most severely damaged red blood cells? They just hemolyze directly in the bloodstream. But the partially damaged ones get flagged as abnormal.
So macrophages in the spleen literally take a bite out of the damaged red blood cells to rip out the denatured hemoglobin. This leaves us with those classic bite cells and hemogosts, cells that look partially or entirely empty.
But what exactly are those macrophages biting out? Heinz bodies. When that hemoglobin oxidizes and denatures, it clumps together into these dense masses called Heinz bodies, which severely damage the cell membrane. But here is the major trick for us in the ED. Heinz bodies are 100% invisible on standard May-Grunwald Giemsa smears. You literally cannot see them. You absolutely must order a supravital stain, like Brilliant Crescel Blue, if you want to visualize them.
All right, part 4, emergency management. Let's lock in the clinical algorithm.
Managing this really comes down to 3 high-yield steps. Step 1 is the absolute most critical. Identify and instantly stop the offending oxidant trigger. Step 2 is aggressive IV hydration. This is huge because all that massive free hemoglobin being filtered by the kidneys can easily trigger an acute kidney injury, so you've got to maintain robust renal perfusion. And step 3, if your patient is hemodynamically unstable or just has life-threatening severe anemia, you need to prep for packed red blood cell transfusions or honestly even an exchange transfusion.
Section 5. The methemoglobinia trap. Listen, this is a critical pivot, and it is easily the most dangerous pitfall for any ED physician treating this specific population. This trap can be fatal.
Picture this high-tension clinical scenario. You've got a patient who presents with central cyanosis, profound hypoxia, and they're completely ignoring your supplemental oxygen. Nothing's working. You correctly diagnose methemoglobinemia. Great, but you also happen to know or strongly suspect that they have G6PD deficiency. What's your next move?
I'll tell you what your move isn't. Do not give methylene blue. It is absolutely contraindicated. In a typical patient, sure, methylene blue cures methemoglobinemia, but it relies entirely on NADPH to do its job. A G6PD deficient patient simply doesn't have enough NADPH. So not only will the methylene blue fail to work, it'll actually act as a potent oxidant itself. You'll paradoxically worsen the hemolysis and you could very well kill your patient. Instead, your go-to alternative therapies have to be intravenous ascorbic acid, exchange transfusion, or hyperbaric oxygen.
Finally, part 6, summary and key messages. Let's get to the high-yield pearls.
To wrap up this explainer, here's your mental checklist for the next shift. Number 1, prevention is everything. Stop those oxidant triggers the second you identify them. Number 2, if you suspect a crisis, get the smear, hunt for those bite cells, and remember to specifically order a Brilliant Crescel Blue stain for the Heinz bodies. Number 3, hydrate them aggressively to protect the kidneys from hemoglobinuria. And number 4, our biggest rule. If they have methemoglobinemia, never, ever give them methylene blue.
I'll leave you with this. G6PD deficiency is usually completely silent, right up until it isn't. Keeping your clinical suspicion high, strictly updating patient allergy lists, and getting a really thorough dietary and medication history is the only way you're going to stay ahead of a crisis. So next time an acutely jaundiced patient rolls through those doors, will you remember to ask them what they had for dinner last night? Thanks for hanging out with me for this explainer, and stay sharp out there.